Welcome everyone, and thank you for joining us for today's webinar on F.I.T, wear and fit veneer. We're excited to have you with us. The session will begin shortly. If you have any questions during the webinar, please click the question mark icon in the top right corner of your screen. There you can type your questions and we'll make sure to address them during this session. For the hands-on part, the second part of this webinar, please keep your course package with the models and everything close at hand. And please don't forget to have also a curing light and a pair of scissors ready to cut the Teflon tape. Please enjoy the webinar. So welcome in this webinar. We are going to talk about forma injection technique, and for those who are already who already know the F.I.T, the forma injection solution, recently we added a second focus, a second indication, which is F.I.T for veneers. So today, maybe you already know the solution, maybe you already did some wear cases. So then this part will be a little bit repeating, but then the second part will be new, and we will be discussing new features and new possibilities in this F.I.T veneer indication. In this presentation, we will first talk about the workflow. So I will give an overview, and there we will repeat in short the F.I.T principles, which we know already from the F.I.T wear indication. And then we will discuss how the technique works step by step. And then I will explain what is now new in the veneer indication, all those features. And after this, this will also be sharing a clinical case. And then we will go to the hands-on part and exercise on the model. So basically, from the start, F.I.T has been already on the market now for 4 years. And from the start, we wanted to come with a new solution, a tool to help our clients, the dentist, in their direct composite work. And because of the composition of composites today, and I will show you later, this is now possible to inject also for final restorations with direct composites. And if you look at the picture on the slide, this kind of patients who have severe wear or erosion, of course, you can treat them with, let's say, the classical ceramic solutions, veneers or tabletops or crowns, all that kind of ceramic restorations. But if we talk about the forma injection technique, we are talking about an aesthetic rehabilitation. It can be used for really full rehabilitation cases to solve the occlusal tooth wear, but also veneering the anterior zones, which make them also more aesthetic. And we will talk about this in the second part of this presentation. So we are using a direct flowable injectable composite. In this injection technique, we do this in transparent molds or keys, which are prepared. So this is part of our package of our solution. And the indications, of course, wear, bruxism, different kind of defects, erosion, trauma cases. Of course, you can also do, let's say, smaller zones, only anterior, for instance, instead of full rehabilitation cases. Also there, it's easy and quick solution to come to a very nice aesthetic result in terms of shade and shape. And of course, for the veneering, this also goes towards the trend of aesthetic and even cosmetic dentistry. So first of all, which material do we use? And that's quite important. We are using Genial Universal Injectable from GC, and we chose this composite to be part of the package of the solution, because we know that this composite can be used instead of a paste consistency. So it has the same physical properties as a composite in a paste, and this means you can use it for class 1, 2, 3, 4, 5 as you would use a paste. It's flowable, but it's also injectable, and there's a difference between normal flowable composites and injectables in terms of indication. The injectable composites, they are the strong composites, and they can be used for all that kind of indications like F.I.T, this injection technique. Normal flowables are about 50% filled. That means that the matrix resin is filled with fillers, with particles, and only up to 50%, which keep them flowable. In the former area of composite development, these fillers were microfillers. Today, due to the new technology, we have those nano fillers, so very, very small ceramic silica fillers, and because of these nano fillers, we can, or the manufacturers can fill the matrix resin much higher, up to 70 or 80%, which means that we have a much stronger composite, but it's still flowable and it's injectable. So that's due to this new composition and these new very, very fine fillers. So in the first case, I will show you how we can use this composite for the indication F.I.T wear, and we do this by a step-by-step protocol from this clinical case from the university in Leuven, Belgium, where Professor Peumans treated this young boy who had severe erosion on, let's say, all elements due to 2 liters of Coca-Cola. He drank 2 liters of Coca-Cola every day. So you see this leads to severe erosion, not only on the occlusion and on the vestibular faces, but also on the palatal face. So this is a typical case for this kind of treatments. It's a young patient. It's a quick and easy type of restoration. It's minimal invasive also. We don't really have to prep, so we can help this patient quite quickly. And it can also be like an intermediate solution where the patient can choose after a certain time to switch to final ceramic restorations. But let's take a look at the protocol first. First, it's always the shade taking, of course. With the normal Vita shade guide, you can do this. Then we have the impression taking. This can be analog, but then we always convert it to a digital process in the lab. That means if you send us impressions, we will always digitize those impressions. Of course, if you send us scans, then it's already a digital file, and then we proceed with the digital smile design. So we need impressions. We need also a bite scan or a registration of the bite in the new vertical dimension of occlusion. And I will show you later in a video how you can do this using the leaf gauge technique. So the new vertical dimension, and then optional, you can also build up already one of the 2 central front teeth just to give the lab an idea on the ideal length for the front teeth, and this can be taken into account for the digital smile design. So we receive the scans, the upper, lower arch, and the new bite. And then in the lab, in the ExoCAD software, we will create an F.I.T smile design, building up all those faces, the occlusal faces, and in this case on the incisal third of the anterior teeth. So this is then sent to the dentist, and you can receive this in an open file. It's an ExoCAD file, so you can really turn around the image, look from all angles, and control and communicate if we have to change anything on the design. So this is how it looks, and this is a real wear case where you see that really the incisal third and the occlusal tables are built up. Then as an option, you can go for a mock-up first. So before going to the final restoration with a provisional resin material, we will provide you with a normal putty key horseshoe over the full arch, and this can be filled with the digital smile design. So we receive the scans, the upper, lower arch, and the new bite. And then in the lab, in the ExoCAD software, we will create an F.I.T smile design, building up all those faces, the occlusal faces, and in this case on the incisal third of the anterior teeth. So this is then sent to the dentist, and you can receive this in an open file. It's an ExoCAD file, so you can really turn around the image, look from all angles, and control and communicate if we have to change anything on the design. So this is how it looks, and this is a real wear case where you see that really the incisal third and the occlusal tables are built up. Then as an option, you can go for a mock-up first. So before going to the final restoration with a provisional resin material, we will provide you with a normal putty key horseshoe over the full arch, and this can be filled then also with a temporary resin material. You can also order this on the order form. This is the TempSmart product. You fill up the key, and in one block you can put this in the mouth to have an idea on the physical result of this digital smile design, because then you can really try it out in the mouth, discuss also with the patient before going to the final restoration. So here you can control the midline, the aesthetic help lines, the reference lines, the lateral movements. Everything can be controlled, the speech, and if everything is okay, then you can order the final F.I.T keys to go to the final stage, or you can also, if necessary, adapt the try-in in the mouth. You can grind, you can add more material if needed, and then take a new scan and send us this new scan. So an evaluation stage of the aesthetic lines, and then after optimization, you rescan the case and send us those arches, because these will be then the references to produce the final models. And this final upper model is then created, lower model is created in the software, and then we can print those models. And we also create every time an alternate model. On this alternate model, you can see that not all the teeth are built up, but every second tooth is built up. So we need that model for the upper arch and also for the lower arch, as you can see here. And then we produce the silicon keys in different zones on the models, on both the alternate and the full wax up model. And then we come to the injection, final injection phase. So after the scanning, the mock-up, then we come to the final phase. So here, in different steps, step by step, zone by zone, we will treat the patient's arches, and we start by injecting in the posterior area. And you can first treat the zones in the posterior area before going to the anterior zone. So every arch has 3 different zones. We have the front zone, and then we have left and right posterior zones. So we always start with the alternate silicon key, which you see here on the left. We inject those teeth, and we use Teflon tape on the elements which are not treated in this phase. And then we finish those elements. And after this, we put Teflon on the first injected elements, and then with the second full wax up key, we can inject the other teeth. So it's always in 2 steps. First, the alternate key, and then the full wax up key. A step-by-step procedure, which is quite simple. We will try it later on the model. The only tips and tricks, you need to get acquainted to the use of the Teflon, and I will show you some tips on how to apply the Teflon in the intraproximal areas, etc., in the practical part. So this is the result before finishing, and you see the complete buildup of the teeth. You recreated really the natural shape, both on the vestibular faces. You re-established the nice convex and concave macro structure, and also on the palatal face, you see from the anterior zone, you see you can really inject all the morphology of the cingulum and the proximal ridges. So this is all done just by injecting in the flowable composite in the translucent key. So upper and lower are finished here, and then you see you have a quite nice result, which is easy, which is non-prep in this case, and because if you look, there is a fine line visible between the composite and the natural tooth structure if you have a macro view on this case, like on this picture. And this is, of course, because it was a non-prep case. So if you want to avoid this line, it's important to bevel the incisal edge a little bit, putting the let's say the incisal line or the trauma line more to the palatal face of the tooth, and then you have a more gradient composite and natural tooth structure surface. So this is the end result, and yeah, the patient was very happy because this is at this point still a completely prepless, a minimal invasive treatment. Everything is immediately protected. It's repairable if something goes wrong after a while. If you would have some composite chipping or whatever, it's really easy to repair it intraorally just by re-establishing the inhibition layer on the composite with bonding, and then you can add more composite material on top. So it's quite aesthetic, even though we only use one shade here, only the dentin shade. So you really mimic the natural morphology due to the exact copy paste of the digital smile design in the translucent keys, and then the translucent keys are transformed to our composite. So it's reproducible. That's also always the advantage of digital workflows. With one, let's say, push on the button, as a matter of speaking, we can really recreate, reprint the models very easily, or remake the transpa keys if necessary. So it's simple, it's quite quick and unique workflow, also cheap, of course, if you compare it to a full mouth of ceramic restorations. It's a more economic solution, and in a few easy steps you have a successful treatment. And what is of course important, the Forma or the F.I.T package, Forma injection technique package, is a one-stop shop solution. And this means we have all the tools you need in one box. We have the models, we have all the transpa keys, we have also metal strips to finish in the intraproximal zones. That's of course very important. Then for every zone we foresee one syringe of composite also in the package. We have the Teflon tape and also some rubber wheels to finish in 2 steps, pre-polishing and final polishing wheel. So everything in one package. So this is actually the whole workflow and the step-by-step protocol for F.I.T. It's always the same story. We work in different zones, and we always start with an alternate silicon key and then complete in a second injection phase with the full wax-up silicon key. And this same workflow, we can use this now for veneer cases also, or especially if we focus on the aesthetic zone, on the anterior zone. We have some new features to make this zone even more aesthetic. And of course, if we talk about veneers, it's an option to go for direct composite F.I.T veneers. You can also go for ceramic, lithium disilicate, Emax veneers, of course, or today we also offer a very nice solution, which are zirconia veneers. This is our Zirnier solution, where we use the specific EasyNear shade system. So more information on this. We have also a lot of information on our websites or in the Zirnier webinars, which are also coming soon. So for the veneer indications, first of all, we all know, as I mentioned before, it can be for trauma, fracture reasons. It can be some kind of underdevelopment of certain of enamel or abrasion, erosion, to solve diastema problems or just crowding. And if we talk about those cases where we have crowding, it's of course also ideal to combine these solutions with aligners today in an align and restore philosophy, where we always aim to work minimal invasive, to solve the crowding with a few aligner steps first, and then to continue with our F.I.T injection as a restorative solution. So all those indications are known, and of course also discoloration. This is also a major indication where we differentiate between minor or severe discolorations. And I will show you also on the slides how you can solve this later. So basically, it's always about shape or color, or the patient can come in with a pure aesthetic or cosmetic wish, or it can also be a combination of different indications. And that's important to know because, for instance, if we look at this case, for the first design, we actually closed this central diastema because we didn't know that the patient preferred to keep this diastema. It can be that it's really a characteristic feature of the face, and that patients would like to keep their central diastema. So all this has to be taken into account. And of course, also the fact of looking at pre-restorative alignment solutions, because also for this case, if you look at the second quadrant, you see that we have to add much more composite in thickness than on the 21 comparing to the 11. So from different views, you can see the second quadrant really needs much more material to get the whole arch aligned. And then for these cases, it's really important to realize also that aligners, and then we don't really speak about orthodontics because aligning is so easy today with aligners, with the TrioClear treatment, for instance. In a few steps, you could align these two quadrants to make a perfect arch, and then it would be much easier to achieve color-wise the perfect end result. Because of course you can imagine if you inject much more in thickness on one central element than on the other central element, you can always see shade differences. So this is important to really look at all the parameters, of course, the price difference between ceramic and composite, the lifespan of both treatments, also the desires of the patient, and of course, looking at how invasive the treatment would be. So all this can be discussed in the so-called wish interview with your patient, where of course the aim is to really come close or as close as possible to the expectations of the patient, because if we don't meet those expectations, there will always be a disappointment. So very important to do this wish interview. And if we finally decide, okay, we will go for the F.I.T veneer, the composite injection solution, as an alternative for the more invasive indirect ceramic veneer solutions, then now we have some options to make this choice also quite aesthetic. What do we do? Actually, we follow the same protocol as where, only here, because we focus on the veneer indication, we offer a new concept, and this is the layer concept. This means we offer the possibility to inject in different layers. And the first injection is the dentin core. In this dentin core, we actually copy the natural tooth structure, the dentin mamelons, the dentin core, in the proper volume for a natural dentin structure. And then after this is injected and cured, then we can go to the second injection phase. And in this step, we inject an enamel composite in the exact same layer as natural enamel, mimicking also the value of natural enamel. So we have different enamel composites available to according to the age of the patient. So why is this important? First of all, indirect veneers is a quite difficult technique, and although today there are really good solutions to guide you through this whole process, in terms of prep guides, shade determination tools. So this is all explained in our new Veneer webinars. Still, it is a quite stressful treatment to do a full mouth of ceramic veneers. So that's why an alternative can be, of course, also to use this indirect solution, F.I.T veneers. There is a growing demand from patients towards aesthetic and cosmetic dentistry. So that's why we also pay attention to aesthetics, injection in different layers. And of course, as I mentioned before, in the whole pre-restorative align concept, using aligners first to redistribute the space in the ideal arch to really align the elements. And we don't talk about, real orthodontic treatments here, but for every GP, it's important today to realize that you can really, with a few steps of aligners, prepare your restorative case much better. So redistributing the space to the ideal start situation. And this can all be prepared also in this digital smile design today. So that's part also of our align and restore solution, where we combine our align system TrioClear with the F.I.T solution. So how do we do it? Actually, it's just the same workflow for veneer as we know it already from the wear solution. So we use the same composite. We, of course, have two layers here. The first one is dentin and the second one is enamel. So that's what you see also here on the picture. The yellow is the dentin layer injection. And for this dentin, we have one key, one extra key, and this is the first injection key, where we inject a small layer of the dentin core with a 3D mamelon structure. When this is injected and cured, then we continue with our alternate enamel key in the normal F.I.T protocol, and then the full wax up enamel key. So we need 3 keys if we follow the 2-layer injection protocol. Why do we do this? Why do we offer this? Because, of course, in the zone which is important for our patients, which is also very visible, of course, if we speak, if we laugh, then there we want really to enhance the aesthetics, the translucency effect, the depth effect of those front teeth, and especially in the incisal zone where we have then the 3-dimensional dentin mamelons covered with a very nice specific enamel layer, which mimics the natural tooth structure, the dentin tubuli, and the enamel prismas, giving us the same aesthetics. How do we do it? We use now in our digital library a specific library from Dr. Jan Haito, and this is coming from the well-known book Anteriors, which is already for decades an important book if we talk in the dental world about shape. He has specific shapes for women and for men in this library, and today we have also the option to, as you see in this exocut viewer, the option to get the dentin core build up for every design in this library. So this is the new digital library we use for this F.I.T solution, and also for our ceramic veneers actually. So doing this, we can really offer silicon keys which can be used to mimic the natural build-up of natural tooth. First, the dentin layer is injected, and then the enamel over the top. And if you want, you can even enhance the depth effect more by adding a little bit of translucency, translucent composites on the dentin, just with a brush by hand before continuing with the enamel injection. So it's all in layers, mimicking the natural tooth buildup. And this enamel, actually, we offer two shades. The first one is called GE, and this GE stands for junior enamel. And we use this junior enamel, a high value whitish enamel, for the bright clear shades, let's say up to A2, and for the darker shades from A3 and darker or more saturated chroma, then we have this enamel, which is the adult enamel. And so this is a little bit darker, lower value. So if you would order, for instance, a 2-layer injection F.I.T case, and you tell us I want dentin A2, then automatically we know we have to add the junior enamel. For the rest, the whole workflow is the same as for the F.I.T, where you create your case first using your intraoral scanner, send us the data and the new byte registration. We communicate then with the exocad viewer. You can come back to us, approve it, or ask for some changes if needed, then opt for the physical mock-up as we have seen before, and then go to the ordering the final execution stage, which it can be this 2-layer injection, or of course you can still opt for 1-layer injection. So everything is the same: scans, smile design, and then the injection. So for the smile design, just to show you the exocad viewer, you can really look from all angles and control what was prepared, and then approve or come back to us. And you can, as you can see, you can change the different in the viewer, the build-up or the pre-op scans, turn them a little bit more translucent to really control the thickness of the composite applied on the surface. So in this case, everything is okay, and then we can go to the final stage. Maybe good to know, today we work more and more with face scans, and face scanners have gone through quite some development the last years. Today we are also reseller for the RayFace face scanner, and this is an impressive device which is actually a kind of photo booth, taking an image in less than a second with 6 different cameras of the face of the patient and turning it into a 3D image. And of course, this is just a start, because important is, of course, what we can do now with this image. And that's where the advantage is today in the software, because in the software, in a few clicks, we can upload our intraoral scanners, even our CBCT DICOM files, and align all those different files automatically in the software. It's really a matter of seconds, I would say, or a minute, to align all those different files in one 3D viewer. And today this creates really the avatar of the patient. A 3D patient is then available in the lab, and then the lab has all the facial features and can control really the digital setup in the mouth of the patient. Everything is aligned automatically, and we can really control and also choose the shape of the teeth aligned with the patient's face. So it's really face-driven designs which are possible using those face scanners today. And of course, the whole magic happens in the software, because you really have a kind of virtual face bow, because the intraoral scanners are aligned automatically in the 3D image. So this is part of the data acquisition, the first step of the treatment. Today, a lot of cases start with taking an intraoral scan, a bite scan, a face scan, and then in the software, in a matter of minutes, everything is put together in one image. Also, these reference planes, these landmarks, and these lines are all automatically rendered by the software of these face scanners today. And this, of course, helps to get to a perfect digital smile design. So let's take a look at F.I.T. Veneer case. And this is the first picture where we started the presentation. This patient also has severe erosion. And just to explain you how to take the new vertical dimension of occlusion, you can use this kind of leaf gauges between the front teeth. So this can be ordered from any dental depot dealer. And with those leaves, you can build up 0.1 millimeter per leaf up to, let's say, 1 millimeter or 2 millimeters to increase the vertical dimension. And then you just put some bite registration material between the left and right posterior zones before you continue to scan. So this is an easy way to come to this new vertical dimension of occlusion. Then the left and right bite scans are done, and then you see everything is put together in the software in the new vertical dimension. Okay, and this is what we need then to continue with the design. First step, optional, as we discussed already, can be a mock-up using a provisional resin, just checking everything physical. If this is okay and this looks very nice, we can approve the case and then go to the final injection. So after preparing using the rubber dam, we check the fit of the silicon key. First, the alternate silicon key. Then we can use Teflon to isolate the teeth which will not be injected in this first phase. And then, of course, the edge prime and bond selective etching here, bonding protocol. Yes, bonding, then curing to activate the bonding, and then the silicon transpa key comes into place. And you see on the incisal edge there is an injection channel. This is also what we foresee also in the keys. We have already the injection channel on the proper place made for you. And we always foresee, which is not done in this case, but we always foresee also an air escape channel on the cervical part for this kind of cases. Otherwise, you might have some air bubbles. So we inject in different zones. We have the anterior zone, and then we have the left and right posterior zone. This is because this works quite easy, and it's quite handy to have those smaller keys than instead of using the full arch key. So here with the alternate silicon key, we did the first injection. Then we do a tack curing 10-15 seconds with the blue light. We can remove the silicon key. And you see it's also normal that you have some composite in the channels, both in the injection and the air escape channel normally. And then we can finish these elements already. So you see the whole shape is actually a perfect copy of what we have in the silicon keys. So it's just about removing the injection channel, finishing and polishing immediately, because there is not much grinding necessary here. We have all the features due to the perfect injection. You can use some for the final curing before finishing. You can use some polyvinyl gel, OxyGuard, for instance, or air barrier from GC also. And this avoids actually this sticky inhibition layer on the surface while doing the final curing. And this means the composite will cure all the way to the top, to the surface, without a sticky inhibition layer on the surface. So after the final curing stage, we wash off this translucent silicone gel, and we can start polishing immediately. And it's much easier to polish without this sticky inhibition layer. Okay, so important to finish well in this first stage. Also interdental, use the metal strips, etc., to finish. And then we continue with the second phase of the injection. Now we use Teflon on those first injected teeth, and use the full wax up silicon key to inject the other elements. And then everything can be properly finished. And due to the injection in two phases, we have really created individual teeth, and the patient can use dental floss to clean interproximal, interdental. So that's really important. And you see in this case perfect rehabilitation, even using only one shade here in this case. So this was an injection only using dentin. You see that you have quite nice, really acceptable aesthetics. You also have a full arch. Of course, there is no mimicking of natural neighbor teeth. The whole case and all the teeth are treated, so that makes it easier also to come to a nice result in terms of shape and shade. So this can be an option, choosing also for the veneer or combi veneer wear, because in some cases you have posterior wear, you have anterior wear, but also want veneering on the anterior teeth. So it can also be a combination case. And then you can have the option to choose, I'm doing everything with one layer. Then you can still use dentin or enamel on the anterior zone. If you do two layers, we will always provide a dentin and an enamel color in or shade in the package. So we are starting now more and more with also these clinical veneer cases, injecting in two layers, and we have some very nice results also showing the improved, enhanced aesthetics in the incisal third of the front teeth. And we have some nice case reports also coming, showing also the internal structure, as you can see here, of the first injected layer, the dentin, where you really can see those nice incisal mamelons, quite thin towards the incisal edge, but still the three-dimensional dentin core mamelons, which support, of course, the enamel lobe structure injected in the later stage. So this whole concept, as I told you before, it's really to mimic the natural tooth structure, and also try to come as close as possible using those different composite layers to the aesthetics of natural teeth. If we look at these nice pictures, the whole translucent effect of the enamel and the depth effect in the incisal zone. This is really what make our natural teeth so so beautiful, and this can be really injected today using this two-layer injection technique. So to do this, we have sent you a new course model to practice today, and we will do this step by step. We will start with the anterior exercise and then continue with the posterior. And step by step, for the anterior, we have one extra injection key, which is the dentin, before we continue with the enamel. And on the posterior, we will just use dentin in 2 steps. To finish the presentation, just some slides to show you that also if you have a strong discoloration, like tetracycline discoloration or fluorosis, you can also solve it with composite. So it depends a little bit on the degree of the discoloration, how you should start, and which type of composite we should apply first. So if you have a severe discoloration, first of all, you need enough space, layering space, up to 1 millimeter to be able to hide the discoloration, first of all, and then rebuild the aesthetics in different layers. So then our first layer will be a flowable paint opaque, also a composite, but this is really a paint opaque before we continue with an opacious dentin, and then we can inject with dentin and enamel shades. If we have a mild discoloration, of course, you can solve it by using only dentin and enamel, as we have seen, because the dentin will just hide the discoloration. If it's moderate in between, then we don't need to start with the paint opaque, but we can use just the composite opaque dentin as a first layer. So here, just to show you the different steps, I've put an A4 central denture tooth next to an A2, and after prepping 1 millimeter, we have a severe discoloration, edge prime and bond protocol, and this is then where we should start applying this paint composite layer, which is very thin. It's only 100 microns, so we don't lose layering space, and still we are able to mask severe discolorations. And today we also offer this in our F.I.T package. If you order a masking liner, we will also send you in the package a syringe of this opaque to mask your discolorations. You can use just a micro brush or a brush to apply this, and also cure it with normal blue light. Of course, this composite is very, very opaque, so you really need to perform the final curing, 40 seconds per layer, to do a final curing before continuing with other composite layers. Otherwise, you would see that the paint opaque would mingle with the composite later on. So make sure it's properly cured. The second step after this paint opaque is always use a very thin layer of opacious dentin. So also this next to the normal dentin A2, we also have an AO2 available, and this is the opacious dentin, which has to be applied on top of paint opaque, or to mask as a first layer without paint opaque moderate discolorations. All right, so this is a very thin layer, and you see we have already 2 layers of composite, the paint opaque and the opacious dentin, and still we have enough layering space left for dentin and enamel to recreate our aesthetic layers. So in this case, you also have this very clear line, this straight line on the incisal edge. So that's why we also build up by hand very small mamelons with this opacious dentin. And after this, the discoloration is gone, and now you could continue with the F.I.T, with the silicon keys, injecting your dentin layer first, like this, your mamelon structure, which is prepared in the two-layer technique, and then with some instruments to enhance the depth effect, you can use some translucent composite, flowable or a paste, very thin layer over and in between the mamelons in that incisal zone, which really creates the depth effect. And then you can just inject your enamel layer. If you would do this by hand, now you would have to continue with enamel, build it up a little bit too big, and then make sure you have all the macro and micro features, perikymata lines, lobe structure, everything done by hand, and then finishing with burrs to come to a perfect shape, looking at the transition lines, vertical and horizontal, to make sure that optically we have the same elements. So this is by hand, a lot of work in building up and finishing, and all this can be just avoided by injecting in the transfer molds, in the keys. Yes, and then you see that using that opaque layers first, and then just continuing with dentin and enamel, you still are able to come to a very nice match and an aesthetic end result. So this is it for the presentation. I hope this was interesting. And just to finish, to show you the order form, because this is of course important to choose and to use this order form, to send us this order form along with your impressions or scans. To first choose the type. Are we talking about a normal F.I.T wear case, or is it an F.I.T veneer case, or a combination? Then you can cross both boxes. And if it's a veneer, of course, we need to know, do you wish to follow the one layer injection? And in that case, do you want to do this with dentin or with enamel? And if it's two layer, of course, you always get dentin and enamel. Then we just need the shade. And then it's about diagnostic phase. So which zones will be treated? Then you can opt for the try-in, and then the final injection phase. Here you can order your shade, your opaques, your enamels if necessary. And then this is the final step of the orders process. So then we come to the practical part. We do these courses physically, but also online as today. So that means for this practical part, I will switch my camera on, and then step by step we'll guide you through the exercise. Just as a final information, interesting for you to know, we have also specific webinars where we explain the complete align and restore concept. I mentioned it throughout this presentation, but we also have a separate webinar on this, where you learn everything about aligners and combining it with restorative treatment options. We have this F.I.T courses today, but also interesting as an alternative for F.I.T veneer, opting for ceramic veneers. And there we have a new product, a new solution, which is the Veneer, and coming very soon. We have some very nice webinars where also Professor Ziad, an expert on veneers, will explain the full digital protocol on how to do these digital veneers today. So very nice webinar. I can highly recommend this. So let's go to the practical part. Thank you for your attention up to now, and I will just finish the presentation here. And then if you would have questions in between, you see that there is a question box in the right upper corner. So there you can also type your questions. And if I see questions coming, I will read them out and we can discuss them also right away. So now I will switch to my camera. I hope that everybody has the model ready to work and has a curing light and also the composite and the transpaquets ready to go. We will work on this kind of printed model. Let me just take away the background, that will be easier. 1 minute. Yes, this is better. Okay, so we will work on this kind of model, and the first exercise will be the veneer, so the anterior exercise, and then we finish with the easy posterior exercise. We start with the anterior because then everybody has the full concept, and then everybody understands the difference between the two options. Okay. There is one question from Boris. How long does it expect to last compared to an indirect veneer? Well, good question. Thank you, Boris. Actually, we always have to think about, of course, if you do indirect veneers, maybe you mean the longevity of the restoration. For the protocol, of course, it's less invasive, so you don't need to prep. You can just inject, and let's say to do a full mouth case with F.I.T, you have to foresee a few hours, you know, because you have to take the time to inject the different faces. It's always about adding applying the Teflon, removing the Teflon, finishing the elements. Don't forget, for a full case, you maybe treat 24 elements. So this takes some time. And most of the dentists we see, they actually book 2 appointments. First one, they do, for instance, all the posterior zones. And then in a second appointment, after a few days or the next week, they do the anterior zones. And of course, you can use always the full wax up with also the provisional material, and just send the patient home with the provisional en bloc also, to see for a few days if it's too much to do the whole treatment in one appointment. You will see once you get the hang of the workflow, it goes quicker and quicker and easier. So that's also why it's nice to do this on a model first, to really know all the tips and tricks before you do it in the mouth. If we compare then this kind of composite restorations with the ceramic restoration, of course, it also depends on different parameters. But let's say if the composites of today are very high quality materials, if we cure them well, if we finish them well and polish them well, we have cases for several years already still looking very nice. So it all depends a little bit also on the hygiene of the patient, etc. But let's say the composites of today can really live up to 8 or 10 years. We have cases like that, which still look amazingly good. And don't forget, if something would, let's say, fail, if you have a minor corner chipping or whatever, after a while, it's easy to repair. And that's, of course, also important in comparison with ceramic veneers, which are, especially in feldspathic veneers or lithium disilicate, still quite brittle and difficult to repair. So that's one of the reasons actually why we also really go for this new indication, zirconia, as a material for indirect veneers. The problem with zirconia, in short, was always that you could not use the adhesive cementation protocol. But today, also due to the nano technology, actually, we have a spray of lithium disilicate, a very thin nano spray of lithium disilicate we can add to the cementation surface of these zirconia veneers. And this is then sintered in a ceramic furnace, which means we have a small, thin glass layer on the inside of the zirconia veneers, which can be etched using phosphoric hydrofluoric acid. So this can be cemented then the same way as lithium disilicate, as Emax veneers. And this is all explained in this webinar coming on the 10th of December, very soon, where Professor Ziad is explaining this new solution. Okay, so let's go back to our model. What we need to prepare here is the Teflon. So if you take the Teflon roll, we just need a few short pieces, 1.5 centimeter of Teflon, and we just cut off 3-4 of those pieces, because this is what we need also to before we start injecting, to isolate the teeth in between. Yes, so this is just to prepare. And then looking at the silicon keys, for the anterior zone, actually we have 3 silicon keys, right? And this is important to take a good look at what you see in those silicon keys. The first one we are going to use is the dentin silicon key, and this is the one where we have on all 4 elements where you see the mamelon structure. Yes, so you clearly see that here on all those elements you see on the incisal edge there is a mamelon structure. This is the dentin key. That's the first one. And then the second one is the alternate enamel. So here you see that the 12 and the 21 is completely built up. Yes, so this is the first enamel injection, alternate. And then we have the full wax up key where all the teeth are completely built up. So this is the last injection key where we are injecting the 11 and the 22. Yes, so this is the third one. So going back to the first, you see that there are no injection channels and air escape channels prepared here. That's because I want in this course to do it ourselves, because then you know also how you can make those injection channels, and that's important if you need to create extra channels. If you have a certain part of the tooth which didn't flow well in composite, or a cusp on a molar, then you can create an extra channel there like this. So what you can do is, if you take your composite box, you open it. In the box you have a syringe, and you also have this injection needles, and we just take an injection needle to create those injection channels. So you can bend the needle, make it quite straight, and then it's easy to push through the key. So this is how we create the injection channels. On the incisal edge, always from the inside out. So that's really important, because we want, yes, I'm pushing inside out through the silicon, and then you see you have a very small part of the silicon material on top of the injection needle. So this, we have to remove this first, and before we take the needle out, yes, and we do the same on the other teeth. Always remove before you pull back. Yes, same on the lateral. Yes, so on all four, now we created those injection channels. Yes, so it looks like this. Yes, and then we need to create the air escape channels, also always from the inside out. And those channels, we create them on the cervical part, in the cervical third. Yes, always remove the silicon, just push through on the four elements. Why do we do this on the cervical? Because then we can really see while we inject the composite that it runs in this towards the cervical part of the tooth, and when the composite fills this cervical air escape channel, then we can stop injecting, hold a little bit of pressure on the plunger of the syringe when we remove the syringe also from the key, because otherwise we create an air bubble in the incisal zone. Yes, so the whole success of the injection phase is actually determined by controlling pressure on this syringe. Yes, on this plunger we need to make sure that we don't push too hard. If you push too sudden and too hard, the composite will just be injected into the silicon key under a lot of force, and then the composite doesn't have time to fill the whole area, and you will create air bubbles. Yes, um, um, like this. Yeah, so we have yeah, we have an air escape, an injection channel here. We have an air escape channel there. Yes, and we need actually the composite to come in here. Yes, well, actually the canines, we don't do them here in the exercise, so only those two will be injected. And we need the composite to slowly fill the whole area and go to the cervical area. Yes, just give the composite time to fill the area and then to come out here in the air escape channel. Yes, so the pressure very low, and sometimes it can help also to put the syringes on a heater, or in the composite heaters. You can also have those where you heat a little bit the composite to make it even more flowable. If you can imagine, if you have to inject in different layers, right, the dentin layer will be quite thin towards the cervical part. So the more if it's a little bit warm, the composite, it's easier to have the composite flowing in those very thin areas. Yes. So make sure for the dentin that we have the A2. Yes, this is the dentin shade. Don't use the junior enamel here. Yes, first we need the A2, and then for the second step afterwards we will use the junior enamel. That's the enamel. A2 first. Yes, don't use the same needle as we have been using to create the injection channels. We use a new needle because there can still be a little bit of composite of silicon in the tip. So make sure always to use a new injection needle. Yes, and now this is ready to inject. On the model, we just need to apply the Teflon, and we apply Teflon on the 13 on the K9. Yes. What is easy is always to overlap a little bit the neighbor tooth. Yes, just 0.5 millimeter. You see that I apply the Teflon 0.5 millimeter here on the 12, on the distal side of the 12, and that's where we have to use some floss to push the Teflon in the interproximal zones. Yes, and by doing this, we have actually perfect in place and really can make the Teflon stick in those areas. We also put Teflon on the 11. And why do we do this? So you can see in the second key we are going to use for the enamel. Yes, you can see that here we will inject, that's the alternate key for the enamel. Here we will inject the 12 and the 21, right? So we have to apply Teflon on the mesial side of the K9, all over the 11, and also on the mesial side of the 22. Yes. So the 22, just like that, and I still need to push the Teflon in between. Yes. Okay. So that's it. Then we put the dentin key in place. So we do this phase, although it's only one key for the 4 teeth next to each other. We don't have an alternate key for the dentin. Why? Because after injecting the dentin, we can still use a disc to separate the teeth if necessary, or some metal strips. You know, you can just go in between before going to the enamel phase. It's only for the enamel that we really need to create the perfect contact points. Here, the dentin is actually not really towards the contacts, right? It's only for enamel that we make the actual contact. So now we are ready to inject with the dentin. Just yes, we put the needle inside. Make sure not to create an extra channel now. Just follow the pre-perforated channel until the needle is inside. And now with a little bit of pressure, yes, you just very controlled see the composite coming into the silicon key. So I just give the composite time to fill the area. If I would push too hard, I would just have composite all over the gingiva. It would go over the gingival line on the mucosa. Just give the composite time to find its way in this very thin injection area, and just come out of the cervical air escape channel. Yes, so the air escapes first, and then we have some composite in the channel, and then I keep pressure on the plunger. I keep a little bit of pressure, just a little bit, when I take out the syringe from the incisal part, because I want also composite in the injection channel. Yes, so now I have composite here and there in both channels. Yes, and that's perfect. Then I know I will not have air bubbles. Yes, so then I take my curing light and I just pre-cure already this first injection. Just 10-15 seconds pre-curing sets the composite, and then you can continue with the second tooth. So it's actually an advantage that we have some composite in the channels, because this now keeps also the key in place. Okay, so we go to the second tooth we have to inject. Yes, same story. Just give the composite time to fill the whole area. The trick is really to be patient and see and control. You know, the keys are completely translucent, so you can really see what's happening. Give it time to reach the air escape channel before you pull back. Keep the pressure. Yes. And that's it. Yes. So some composite in both channels again, and then cure. Yes. Okay. Okay, so those are done. So what we do now is we take away the key. Yes. And now we can, if we have a little bit of overflow, we can just take it away with a scalpel. Yes. And now we just have to finish those two, um, um, not by polishing, but just making sure, of course, that because we still need to add enamel on top, but just making sure that the intradental zones are free. So taking away the Teflon and using again some floss or metal strips to make sure that the second injection can be done, and that we can still apply Teflon tape in the next step. Yes. So always take away the Teflon. This is actually the most time consuming if you do this treatment. As I said before, it's really controlling the Teflon, taking away the Teflon all the time, using the floss to go down to check, you know, and this is always taking a lot of time during the treatment. So it's really an advantage if you have an assistant who can already prepare the Teflon, who can help you with applying and taking away the Teflon. Of course, in this stage, as I said before, use the metal strips, use a disc also if you have a little bit of overflow in the intradental zones. That's of course no problem, because the actual contact zones will be created in enamel in a later stage. So you have those metal strips also in the box, and you can just use those to make sure you can apply the Teflon for the next stage. Yes, like this. Okay, so now just before we go to the two other elements, injecting them with dentin, make sure please to also take away the channels. If you have some channels here, you see there's a small part on the incisal edge. Otherwise, the silicon key will not fit anymore. Yes. So now we go to the second stage. So now we apply Teflon on those pre-injected elements, and this is actually what we always repeat. It's always about placing Teflon, pushing it in the intradental areas, and then injecting the second stage. Yes. So that's 1. 2. Okay. Yep. And then here we need also some Teflon on the mesial side of the 23. Overlapping the distal of the 22 just a little bit, and then with the floss wire you just push it in between there. Okay, we have already the channels there, so after edge prime bonding, you just continue with the dentin, second phase injection. Yes, find the channel and just give the composite time again. Keep the pressure. Light cure. Pre-curing just 10-15 seconds. Oops, and then we go to the second one. Okay. If you think, like I said before, if you think that the composite doesn't run very well, then it might be good to keep it a little bit warmer. Just put it on the heating, or the same with paste. Sometimes in summertime, your composite is so warm that it runs everywhere. If you want to build up composite, then it might need some other consistency, so then you can put it in the refrigerator. Yes, but maybe but the way they actually put the composite, the material, in the syringes is by heating it and just filling it when it flows very easily into those small syringes. So it doesn't affect the physical properties to heat the composite. Okay, so we take away, and now you see the result of um, this first injection. Yes, we have a dentin layer. Yes, we have some small mamelons already on the incisal edge. Make sure again with a scalpel or whatever that we don't have any residues from injection channels or air escape channels, because this would interfere with the fit of the keys for the next step. And then make sure we can apply Teflon again. Yes. Okay, so just check with your metal strips if you can go into proximal. You really need to strip a little bit, and at this point, of course, as I mentioned, you can use also Soflex disc or whatever to do this if you would have already a contact point now. Okay, so that looks good. So now we have the dentin is done and ready. We still have the shiny sticky inhibition layer on the surface, and you see, if you look very closely, you see also that you have the three-dimensional lob structure. You see a little bit more volume towards the middle and the cervical part, and then down to the incisal, you see that the composite runs very thin with three mamelons, three major mamelons, the mesial, central, and the distal, and these will support in the end and the three enamel lobes. Yes, so this is exactly the copy of the natural tooth structure which we take over from the design stage. Okay, so now the dentin injection is done. So now we go to the first enamel injection key. So this is the one where we inject the 21 and the 12, yes, and you still see that 11 and 22 have the mamelons, so they will fit on the mamelons, and this means we have to apply Teflon on the 13, on the 11, and on the 22, yes, and we need injection channels in this first alternate enamel injection key on the 12 and the 21. Yes, the 12 and the 21. So we take a new tip, yes, and this is quite a layer of enamel we inject. So now we can create an injection channel and an air escape channel next to each other on the incisal edge. Just one on the mesial and one on the distal edge. Yes. Like this. Okay. And then we have the Teflon step. First piece. K9. Yeah. Second piece is on the is on the 11. Yes, and then we have the third piece, which is on the 22 on the mesial side. Okay. Okay. So that's it, and then we are ready to inject. Yes. Key comes into place. And now we take the junior enamel. Yes. Junior enamel, which is a quite high value enamel, quite whitish for young patients. So make sure always to turn the tips when you put them on the syringe, because if they are loose, the composite will come out in between the syringe and the tip. So make sure to turn them and firmly on the syringe. Yes. And then we have always a little bit of try that the composite comes out easily, and then just take, for instance, in this case, the distal injection channel and inject the whole enamel layer. Again, give the composite time to fill the area, to reach also the cervical point. Yes. And once it reaches the gingival line, we have it already in the air escape channel and then ready to cure. 10 seconds before we move to the next one, which is the 21 again. Yes. Of course, here also you can even make two air escape channels. If you want, you can create another one here in the cervical, and then it's and then you have on both sides. Then it makes it also easier to flow and to avoid air bubbles. It's a little bit a habit on how you can control also the injection of the composite and the flow of the composite in the silicon key. Okay. So curing, that's done. And then we have to finish those two, because now we have already the final shape and enamel. Yes. So now we take away the Teflon again over and in between the teeth. Yes. Use again some scalpels or some strips to remove the Teflon. And then normally now we really have to, you see that you have very nice, you have the lob structure of the enamel, you have some incisal translucency on the incisal edge, just like a natural tooth. Yes. And this is of course for sure, if you look on a black background like the oral cavity, then it's even enhanced, and then you really see the natural opalescence and depth effect, the translucency of the tooth. But what you also see is the very next to the macro structure of the tooth. Yeah, you see the three lobes of the enamel, which are supported by the dentin mamelons underneath. But you also see those very fine horizontal lines, those perikymata lines. So that's the microstructure of the front teeth. And both macro and micro structure are just taking over from the digital design in the translucent key. All those details are in this key. It's a very detailed key and material, which has the excellent shore features, and it really makes it possible to copy paste all those details from the build-up. So that's really important, because that means we don't have to finish doing that. We don't have to grind. We don't have to copy those perikymata or macro structure anymore with burrs. You just can finish using polishing wheels. Yes, and also these polishing wheels are in the F.I.T kit. They are available, so you can use those to finish actually in two stages: first pre-polish and then final polish, to have really a ceramic shine on the surface. Okay, so now we come to the final step, and the final step is the full wax up injection key. And with this full wax up injection key, we inject the two final elements, which are in this case the 11 and the 22. Yes. Okay, so again we need Teflon. After we would have finished and polished, those first two elements. We put Teflon over them. Yes. Push the Teflon again interdental. Yes. That's it. Okay. And then the final one on the mesial side of the 23. Okay. And now we have the final key. Yes, this is the full wax up key. Yes. So again, we take a new tip. Yes. And now we make an injection channel on the 11. Injection. Air escape. And I will make a second air escape also on the cervical. Then you will see also this helps in the total injection phase. And then on the 22, same story, one injection, two air escape channels. Put the key in place. Again, we need, of course, the junior enamel here. And just make sure you give the composite time to reach both of the injection channels. So using one or two, normally we foresee one injection channel, but I just also want to highlight in this course that sometimes it can help, you know, if you have to inject a very thin layer or whatever, feel free to add more injection channels if you want to do that. Or if you think it's difficult, or if you have air bubbles, maybe it's because you are a little bit too quick with the injection, or your composite is a little bit too stiff, too cold. So these are all tricks which can help doing that. But you see, after a while, you will start to get the hang of this, and you will do both at the same time before curing even one of the elements. You just take them at the same time, pre-cure, and then you can finish and polish all together. Okay, so remember, when we cure at this stage, it's still curing 10 or 15 seconds, so it's just pre-curing. Yes, this is not a final curing step, and we need final curing for the final finishing of the restoration, right? So you really need to do, depending on the light and the output, but let's say standard curing of 40 seconds per tooth to have a good final curing step before we start polishing. And don't forget, like I showed you in the presentation, you can always use some kind of air barrier or polyvinyl gel oxyguard to help the curing and to avoid the sticky inhibition layer on the surface. Yes. So now you have all the four teeth injected. Yes. We have the perfect shape, we have the perfect length, we have the perfect macro and microstructure on the surface. So now it's just about removing the Teflon in the interproximal areas, also with some superfloss, and then just start finishing and polishing with polishing wheels. For the polishing wheels, we have those also in the system. So these polishing wheels, they come in the F.I.T box from Eve. These are the Diacom twist, and there is this red one to pre-polish. Don't go over 5,000-6,000 rotations per minute to pre-polish with the red one. This is the hardest one, and then this already gives you a nice pre-polish, and then the final polishing is with the white one, and then you can go up to 10,000-12,000 rotations per minute. Always make small circles on the surface. So this means, yes, just with your brush you go like this, and pre-polishing 6,000 rotations per minute, and high polish 10,000 rotations per minute. Like this, you will really use the diamond paste, which is on the silicon disc. These are pre-impregnated with diamond paste. If you go faster, yes, then the paste will just fly off in the nose of the patient, and you will not have a shiny surface in the end. It takes a long time then, and you keep on polishing, and you don't have the shine on the surface. So that's all influenced by the polishing speed. Yes, the disc need control speed to come to a good result. Okay. So and then actually, if we do then the posterior exercise, it's exactly the same story. Yes. So here we only have two steps. Yes, we have one alternate silicon key, and the other one is the complete build-up silicon key. So we always start with the alternate. So this means we will first inject the 4, yes, and the 6. This means we need Teflon on the 3, on the 5, and on the 7. Yes, 4 and the 6. So we take 3 pieces of Teflon again, one on the 3, yes, one on the 5, yes, and then one on the 7. Okay. The floss, we push it in between. Even if you have 2 layers of this Teflon, it doesn't really influence. You always can create nice contact points. If you would turn it around, then it still gives you the perfect result. Yes. So what I wanted to mention also for the front, for instance, you still can see that it's a little bit yellowish, but if you would do the final curing for 40 seconds, then you really have the end aesthetics, because then you activate the light initiator, the camphor-quinone, in the matrix resin for 100%. And this camphor-quinone, this light initiator, is actually a yellowish product by nature. So you have to activate it 100%, and then it becomes, let's say, translucent, and then you have the end shade, final shade of your composite. So if you think after pre-curing it still looks quite yellowish, remember that's not your final shade. You need to perform the final curing to get to the final stage of your composite. Okay. So here we are ready to inject. Yes, and now we have to make again the injection and air escape channels. So here for the molar, yes, we are going to inject this incisal part. So this means we are going to have an injection channel on the mesiopalatal cusp. here of the 6, we inject here because in the mouth the syringe will come here, and it's easy to reach this mesiopalatal cusp. Yes, here we have the cheek. Here we can inject easily, and we need an air escape channel on the other side. So this means on the distal buccal cusp. Yes, there we need the air to escape, and here we inject. Okay, so again, give the composite time to fill the area, to find all the corners of the restoration, the cusps, and to come out of the air escape channel. Don't push too hard, do this controlled, and then you will see you will really avoid air bubbles. So to create the channels, again, we take a new tip. Again, inside out, also on the premolar, just on the 2 cusps, the palatal for injection. Take away the silicon again from the tip, because this is not to be, otherwise, if we pull it back and we don't take away the silicon, it can stick in the channel and you could inject it into your restoration. So this is, of course, what we need to avoid. That's why we pull it away before we pull back the needle. Yes. So injection and air escape. Up. Channels are created. Yes. So we will inject the 4 and the 6. Key in place. Here we need to inject with the A2. Yes. The palatal, we go in. Yes. And now, just to remind you, yes, we have the needle coming in here. Make sure that you don't touch with the needle here the surface of the tooth, because then it's impossible to for the composite to come out of the needle. So you need to be here in the middle or here in the front end zone of the key. Yes, that you can really extrude the composite easily. If you make contact, you will be pushing on the plunger, and then suddenly the composite will splash out and will be everywhere except in your key. Yes, so go in with the needle. Yes, and if you feel you make contact, just pull back a little bit, and then you can inject. You can even choose the direction and start injecting. Yes, you see that it fills the first cusp, runs to the second cusp, the buccal one, goes into the air escape channel. Keep a little bit pressure, and we have composite in both channels. Yes. Tech cure with the blue light. And then we go to the second one. Make sure to find the channel and not to create a new one. Wait a minute. I need another tip because I cannot find the channel anymore. Okay. Pull back, and then we inject. And you see that you really create very nice and very easy those cusps, those fissures. Give the composite time to come out of the air escape channel, and then just pull back, and then we have everything ready to cure. So it's amazing. I've seen already a lot of cases in practice done, and we've documented them, and then you really see how perfect the occlusion sets and how little or nothing is necessary to finish after the injection phase. That's because actually the digital smile design is so perfect and so perfect copied in the keys, yes, that that you really have a very nice occlusion and a perfect. I mean, imagine you have to build this up by hand. Yes, that's almost impossible to do. Is this to do it this beautiful? Imagine that you would have a small air bubble somewhere. You can do it freehand also and just fill it up now, right? With your composite. I mean, nothing changes also on that part. You just can treat it as a normal composite filling. If you still have the inhibition, the sticky, shiny layer, you can just add more composite. If not, you just have to add a little bit of bonding first. So now, second step, yes, we remove again the Teflon, and you see, actually to inject in 2 stages, that's really easy. It's only about adding Teflon, removing Teflon, and remember, normally the injection channel and the air escape channel are already prepared, right? So we prepare this in the keys in the lab already. So you just need to put the syringe in there and inject. So now we put some Teflon over those elements which are already done. Yes. And now, of course, it's important to also push the Teflon in the fissures, for instance, here of the molar, because otherwise, yes, we would have the Teflon, let's say like this, and then the silicon key doesn't fit. So we need the Teflon really to follow the morphology of the tooth, going down in the primary fissure, that the silicon key can really fall into place easily. Yes, so that's important. So make sure with an instrument that you push it down, or with your finger, just push it down into the fissures. Yes. Here the 6 is quite wide and large, so I need 2 pieces of Teflon to get it in between the mesial and the distal area. Yes. And then on the 4, right, like this. Then again, make sure that it's interdental. Yeah, and then we are ready to inject with the complete build-up keys, the 5 and the 7. Okay. So the 5 and the 7. So now we need the full key, right? 5 and 7. So that means we need again to take another tip. The 5 pushing through the injection channel, air escape channel on the buccal cusp, and then mesio-palatal cusp for injecting on the 7. Yes. And then air escape on the buccal-distal. Okay. Key into place. And with the same A2, you can then inject those last 2 teeth. Find the channel. Again, don't push the needle too deep. Oops, I was injecting a little bit too much. and that's it. So you see, I even turn sometimes the syringe and try to position the needle towards the air escape channel. Yes, that you really control the direction of the flow of the composite and make sure it reaches all the cusps. If you see that it's forgetting a cusp, you can really turn the needle towards this cusp and make sure you put some pressure there to have it flowing really everywhere. So it depends really a little bit on the, let's say, on the morphology, where to pay attention to. If you have those nice posterior morphologies prepared in the silicon key, it would of course be a shame not to take them over in your composite. Okay. Again, pre-curing, and then we have the final curing done. Yes. So this is it for the steps. Yes, 2 simple steps for the posterior zones. And let's say you have a real case tomorrow. I would suggest start with the posterior zones. Do in 2 steps the injection here, yes, and then so left, right, upper, lower, and then for the front, for instance, you can just do with the full silicon key, yes, everything at once with some provisional material if it lasts too long. Yes, if you would want the patient to come back for a second appointment and then just do the final injection of the front in a second appointment, where you can also take the time then to finish everything properly and polish everything again. Yes. So this is the whole course and the practical part. I hope everybody has seen a little bit how it works and how you can work simply in different steps to come to a very nice end result. And let me just check at this point if we have some questions. Yes. Can you later explain the front section and which trays we have to start with? The first one is dentin layer with the mamelons alternating question mark. Then the second one is enamel alternate. Okay, I will explain again. So for the front, yes, for the front there is only 1 key, yes, for dentin. So that means in total for the front, if you inject in 2 layers, yes, dentin and enamel, you have in total 3 keys. Yes, the first one is the dentin. Yes, so with the dentin key, yes, with the dentin key, we inject the dentin. Yes, like this. Okay, so this is the dentin, and this is 1 key. Yes, and this is 1 key for all the front teeth. So if you have your whole front 6 row of 6 anteriors, you use this 1 key. Yes, you don't really need an extra alternating key for the dentin because you don't make contacts here, right? Yes, here in the contact zones, and I exaggerate a little bit the width, but this is for enamel. Okay, yes, this will be injected in enamel. Yes, these are the contacts, like a natural tooth. You have enamel around the tooth. Okay, the dentin is the core. So you have 1 key for dentin. Yes, you inject with the 1 key all the teeth, and I just also applied Teflon and used the a kind of alternate injection method with the same key. Yes, just to keep the interproximal zones open. You don't really need to do that because you can just inject everything like that and just take a disc and separate them afterwards again. If you have a very small disc, okay. But I don't have a burr here or a disc, so that's why I also used some Teflon to keep the interproximal space open. And then after the dentin, yes, then you go to the alternate enamel, yes, alternate enamel, yeah, and then the full enamel, yes. So in total, 1, 2, 3 keys, 1 dentin, because we can use a disc to separate, and then only for the enamel, because then we cannot separate anymore with the disc. We need really the contact points. So there we have really the alternate and the full key. Okay, I hope that's clear. So that's why for the dentin we only foresee 1 key, because you can still use also strips or just a disc to separate if the composite would flow a little bit in between, or you can use also the Teflon like I did. Okay, if we have no more questions, then I think I will wait just a minute. If you have questions, you can still type them. Of course, if you have questions popping up later on or before you would start treatment or whatever, you can always contact us or me, and I will be happy also to assist you with questions further down the road, because sometimes everything is not clear, or at this point there are no questions, but I can imagine if you have a certain case, then questions might pop up. So don't hesitate in that case to come back to us. Okay, we have also in a lot of countries, we have meanwhile F.I.T specialists who give also courses in their own language and practical courses. So there's always a specialist available on location also who has expertise, and if not, we have also our internal teams to assist. Okay, so meanwhile we've done thousands of F.I.T cases, so we build up a lot of experience both on the design stage and also on the execution stage. So any questions, we are here to help you, and of course we can always learn and use that info for next courses again. Okay, so I don't see more questions coming, or one other. When you do crowns and fit, for example, for bruxist, do you recommend to finish the crowns first before doing F.I.T? So what we sometimes see, or in a lot of cases, is that a F.I.T case is performed, and then we would, for instance, scan after a while the posterior F.I.T restorations, like the molars or the sixes, upper and lower, once they are well adapted also to the new bite. Yes, and the composite behaves a little bit like natural tooth, so it will wear off if the bite is not 100% correct. Also, and once this is all set after, let's say, a few months, then you can rescan, and we can use also those data to design the actual monolithic ceramic restorations like the IMAX or zirconia. So then you can go to tabletops or onlays in ceramic and create, for instance, table stops as stops, occlusal stops on the molars for those bruxist patients. Another thing is that we have a lot of clients, they just also order they also order a splint from the start, so that immediately after the F.I.T treatment you have a splint also available for the patient. And we have done some tests also to find a proper material for this splint. And we have this Forma Adapt splint, which is a thermoplastic material. It's a little bit soft on the inside, or it becomes a little bit softer in the oral environment, and it's hard, a hard splint, functional hard splint on the outside. But that means if you put it under warm water, the patient can fit it in very easy. It's comfortable to wear, and it protects from the start the new restorations.
So, as a closing statement, thank you all for joining us today, and also for your questions, for your active participation throughout the whole session. We hope you found the insights valuable and also inspiring for your future F.I.T treatments. And as I mentioned before, if questions would pop up, please don't hesitate to contact us. On behalf of our entire team, we wish you a great success in applying what you have learned today, and of course, a very pleasant and relaxing evening. Take care, and we hope to see you soon in a next session. Thank you.